Hello, everybody. Thank you for joining us on this online lecture. This is Jonathan Weiner. I'm a professor of health policy and management at the Bloomberg School of Public Health of Johns Hopkins, and also a professor of health informatics. I'm also the founding director of our new CPHIT Center. That's the Center for Population Health IT, or CPHIT. I'm very pleased that you found your way to our web page because this is a very exciting time for the field of public health, for the field of healthcare, where now electronic medical records and other types of health information technology, HIT or eHealth, really can be applied not just to medical care, but also to the health of populations, the health of communities. This sequence of slides, both the presentation verbally and online PowerPoint slides, will give you an introduction both to the field of population health informatics, population health IT, depending on your preferred term, and to our new center, the CPHIT Center. So my goals for the various parts of this presentation, which you can listen to live or I believe download, is to offer you an overview of the trends, the frameworks of the field of HIT or eHealth. There are new paradigms and strategies and ways of thinking that relate to population health and the application of health IT to population health. And then I hope to give you an introduction to our new center, CPHIT, giving you a sense of our aims, how we structure the center here at Johns Hopkins, and the types of collaboration we're looking to from all of you. Also on our webpage, there'll be plenty of other opportunities to learn more about CPHIT, but this is really meant as a sort of a standalone intro to the field of population health and a beginning intro to our new center. This is a very exciting time in the field. Over the next few decades, healthcare and public health, both in the U.S. and globally, is going to be entirely transformed via eHealth. Now, what is eHealth? That is for electronic health. It really includes several different domains. Electronic health records, sometimes called electronic medical records, EHRs or EMRs. And in the U.S., for a variety of reasons, we sometimes call that health IT, information technology, or HIT. In fact, the Department of Health and Human Services has an Office of the National Coordinator for Health IT, sometimes called ONC for the Office of the National Coordinator. So in the U.S., we often use the term HIT. Some people also use the term informatics. I'll give you some of the definitions in a moment. Also very exciting, EMRs and EHRs tend to be provider-focused. That is, in America, virtually all doctors and hospitals now have EHRs and EMRs. But just as important is the role of the consumer, the patient, the community. So whether or not it's various types of mobile phone apps, often called mHealth, or personal health records, where the doctor or nurse don't really own the medical record, but the patient themselves. Some people call that, by the way, Medicine 2.0 or Medicine 3.0. And if you think about all the potential consumer applications that people can use on the internet, that would be included in eHealth as well. And as I've already mentioned, it's not just large internet systems or large hospital systems, but small technology, mobile devices, which of course are quite common, not just in developed countries, but also lower income countries, and telehealth. Telehealth is a somewhat archaic term, but it's still often used to define situations where the provider of care and the patient or consumer are in two different locations. And now, whether or not it's a Fitbit or an EKG machine that's worn all the time, but the whole field of biometrics is just in its infancy. Really very exciting for all of you in the early stages of your career in public health. This next slide is the latest from the Center for Disease Control, CDC, health statistics in the U.S. government. And they do a survey once a year, and this comes from 2014. And it shows that over the last few years, we've had a meteoric rise in terms of the number of doctors out in the offices of clinicians around the U.S. in using electronic medical records. And it's gone up even since this 2013 survey. So we were at something like 15% of doctors using electronic medical records at the beginning of the century, 2001, and now it's something like 80-85% or higher. Now, it's true, many clinicians are in their early stage of adopting these systems, but for those of us in the public health field, the real challenge and the main focus of this talk is how do we take this information that is now digitalized and make sure it translates not just into presenting patient in front of the doctor, but also entire communities and populations. And that's what this introduction is about. So if you think about the field of population health informatics, it really is an integration of three disciplines. It's very exciting when teams get together from these three disciplines. One, of course, is the clinical science, medical nursing. Another is the public health or population health science, and that includes what most of you may be interested in, epidemiology, health policy, biostatistics, classic public health services, and what the informatics and IT people bring to the community, information science. And so there is a whole domain of information science that includes the disciplines of computer science, the disciplines of health informatics, previously mainly focused on clinical informatics, doctors and nurses. I call them affectionately the clinical geeks, the doctor geeks, the nurse geeks. These are people that have both clinical skills as well as technical skills, and engineering, as well as library science and information science. So when all of this comes together, we have individuals who are concerned with either population health, that is the integration of medical and public health and information science, or public health informatics, which focuses on the overlap between the health informatics and the public health fields. There is a domain of clinical informatics, which I won't talk about in this lecture, which really does not focus on communities or populations when EMRs are applied, but really the patient in front of you. And that's a very important field as well, but not one that we'll discuss today. So why I'm really pleased to speak to all of you today is that I can think of few changes in healthcare, few changes in public health that will be more profound, particularly as we try to improve the healthcare system's ability to really focus not just on those patients that knock on the door, often too late, but really emphasizing wellness and health for an entire, I often say, denominator population. That is some target that we care about, not just the numerator of those that come into the system. And the implications really are profound, and what you're finding is organizations, public health organizations, healthcare systems, health insurance companies, sometimes called health plans, government health programs like the Affordable Care Act, ACA, sometimes affectionately also known as Obamacare. The implications and the integration of all of these systems with health IT and informatics are really key to the future. The next two slides offer definitions. I will not read them to you. It is confusing. I've been in this field some time, and we're trying to set some precedent, and we've done environmental scans and lit reviews, but there's still not entire concordance with how people use the terms. But what I try to emphasize to my students here at Johns Hopkins is it's essential you understand the ideas. It's good to understand the various terms, but don't be bent out of shape if people use different terms for different concepts or different concepts for different terms. But nonetheless, I offer you our definition of health information technology, HIT, in general focusing on electronic health records and integration of a full array of information technology. Health informatics is a term that's been around for a while, tends to be an academic term, a term of the body of science that studies not just computers but also information. The term eHealth is a relatively new term, is often used in the commercial community or the so-called vendor, health IT vendor. When that word is used, often people that sell HIT and EMRs. And eHealth is often used by the computer scientists as well. Anything that has to do with computers and digital technology and health. So it would frankly encompass all of that. The term telehealth and telemedicine has been around for a while. Originally is actually telephonic, telephones and other ways of two-way communication. But this has to do with care not necessarily being at the same place at the same time. And that, of course, is a wave of the future. The next series of slides will attempt to present an integrated overview of what is happening now in the U.S. and other high-income countries where the electronic health record, EHR, or electronic medical record, EMR, which is provider-focused, really becomes a core of a delivery system, a healthcare system that is enabled by HIT. No two organizations are quite alike, but I thought I would walk you through so we're all on the same page. Some of you have some familiarity with different components of the system. For others of you, it's new. So bear with me if you've heard some of these presentations before. You can always fast forward a bit. But for those of you that have never heard this before, it's really essential for you to understand what follows. So if you think about this starting point, which is really the clinical interrelationship between a clinician and a provider. An electronic health record is usually there in the office, in the hospital, where the doctor, nurse, other clinician takes notes. And yes, that is often called the charting function. And what's so exciting is that information, once it's entered in the chart, pursuant to security and confidentiality issues, which we'll talk about a little later, is available for any application, not just for the doctor or nurse in front of the patient, but also, for public health and for research and other applications. But the EHR alone is not just about charting. We'll get to that in a moment. Now, the personal health record, or some medical care information or public health information for that matter, that's controlled by the consumer. And, I will often use the term patient when someone is in clinical care mode, and a consumer or person when they're just a regular human being who happens to live in a community and not necessarily a patient. Public health, we understand that difference. But increasingly, there is a whole array of information that's controlled by the consumer, by the patient, and not the doctor. But that's not the mindset of most healthcare systems. In a healthcare system, they will often talk about a web portal, various names, various computer EMR companies, Epic, for example, which is used here at Johns Hopkins and a variety of other large healthcare systems, calls it MyChart. Most other large EMR vendors have something similar, but it allows the patient to come into their record. So that's the core. Most of you who are listening either as clinicians or all of us as patients are probably currently experiencing this, and there's been a huge rollout of this core electronic health record. And the personal health record is a little less widespread than the EMR. This slide adds several new important components that often are included in what's called a comprehensive EMR. A doctor on his or her own, if they use the electronic medical record for charting, that is documenting the interaction between them and the patient, that is only one function of the EMR. It is not considered a comprehensive EMR unless it includes the two components that have been added next to the EMR, actually probably a third component. You'll notice we've added the word interoperable EHR, that is community-wide. A single EMR in a doctor's office or in a single hospital does not necessarily talk to one another. And therefore, it doesn't do the primary care doctor much good if he or she can't read what, let's say, the endocrinologist or psychiatrist or OBGYN enters into the record. So an interoperable EMR, and we'll talk more about it, often through a health information exchange known as an HIE, which I'll discuss later, is sort of key to the comprehensive EMR and certainly key to public health, because if you don't have all the information from across the community, you don't have an interoperable EMR. But the other two boxes added, the computerized provider order entry, CPOE, sometimes called just POE because everything's computerized. That is e-prescribing. That is e-order testing. So the doctor or nurse clicks on a section of the EMR, and lo and behold, a test order is sent to the laboratory or sent to the radiology or imaging, or sent, very importantly, for e-prescribing to the pharmacy. This is also usually fully integrated with the clinical decision support, CDS, sometimes computerized decision support systems. This is what many clinicians find very helpful or very aggravating, a little bit of both. Obviously, all of the knowledge available through guidelines and the evidence base is taught in medical school, but it very rapidly changes. I shouldn't say it's all taught. Much of it is taught, but it very rapidly changes and very rapidly exceeds the ability of the human mind to comprehend it all. But a good computerized system is constantly backstopping the clinician, never telling the clinician what to do, but gee, that patient is due for this test, or gee, doc, I wouldn't order that drug for that patient. Do you want to consider another medication? So those are two profound implications, the CDS and the POE, for the future of practice and for the future of those of us interested in population health. We have started to do some work, in fact, coined a new term we call e-iatrogenesis, iatrogenesis being harm caused by the clinical system. And e-iatrogenesis can happen if either the clinical decision support is wrong, telling a doctor to do the wrong thing, in other words, something he or she wouldn't have done on their own without the computer's input, or for whatever reason, the order entry makes a mistake. There was a case in the UK NHS where, in fact, the doctor ordered one drug and the pharmacy received a separate prescription. So those of you concerned with quality and safety, the POE and the CDS can be a two-edged sword. both in general very helpful to improving safety and quality, but can be the negative. Added to the personal health record, you see the box called Home Biometrics. Increasingly, there are various organizations that add to the personal source of information various type of biometric information, such as the Fitbit, such as various devices that the patient might add, can be controlled by the patient themselves or can connect with the healthcare provider. The next series attempts to bring this back to the population health theme of this lecture and is very exciting to those of us in the public health and population health business. So yes, a doctor, a hospital, a healthcare system, integrated system such as, say, Kaiser Permanente or the U.S. Veterans Affairs, where doctors and hospitals all work together, they can provide good medical care on an integrated basis to those that walk in the door without thinking about population health. But those of us concerned about communities, those of us concerned about special populations, could be certain ethnic groups, certain subgroups, certain age groups, those of us who are designing government healthcare systems or private healthcare plans that have a full responsibility not just for patients but also for those who may not come and get care, that is the main focus of this talk and some of the additions that I've added here. So if you think about not just the 5,000 patients that may be seen in a given month or whatever the number is at a certain clinic here at the Johns Hopkins Hospital, but if you think about the 50,000 patients that have diabetes in the surrounding community, that would be the difference between patient and population. If you also want to bring in information, looking at the top left, about public health systems, and we'll talk a little bit more about public health and vital record systems in a moment, but if you bring that information and integrate it in with the EMR data, the possibilities are profound. And likewise, if you take information not just from the EMR, but administrative data such as claims, that is insurance claims submitted to Medicare, our program for the elderly, or Medicaid, our program for the poor, or now Obamacare and the ACA, which is often made up of Medicaid. Those data can be fully integrated. So if you think about it, if someone has eligibility for Medicare or eligibility for a health maintenance organization, HMO, and we know they have diabetes, but they never come in for their preventive care, never come in for testing, or we know that a woman of a certain age hasn't come in for a certain screening, or a child for their immunization, we do not know that necessarily unless we understand the denominator. But now the possibility for integrating it all digitally is fairly profound. The last slide of this series reminds us, and some of you have interest in research and expanding our scientific base. All of you are interested in using the evidence base to make sure we know what works, what doesn't work, who should get a test, who should get a medication. The new field, often called learning healthcare systems, where all of this is integrated in real time and we understand what works and what doesn't work. Many believe that not that the randomized controlled trial RCT will disappear in the future, but it will be entirely different. Think about this. In some years hence, when you know every type of service everybody received and you know every single outcome and no one is left out, the possibilities for expanding the scientific base are really pretty profound. So any of you who are interested in research as a career is great opportunity. And all of you will be interested, and you'll see the arrow goes both ways, in taking the knowledge base and using it to improve the digitally supported medical care system and population system. In case this wasn't confusing enough or exciting enough for you in terms of the future, I've only been talking, fairly focused on structured medical care systems and structured public health and vital record systems and structured insurance and health plan and government systems, but that's not all. That's not what's happening out there. It goes well beyond that. The whole area of genomics, sometimes called bioinformatics or computational biology is my preferred term. Today, as I'm recording it, the cost of doing not a full genome, but a fairly extensive breakdown of everybody's genetic makeup can be in the low thousands. And so there's some organizations that are now starting, through so-called biochips, very computerized opportunities to understanding your personal genetic makeup, that one day will be integrated into the EHR, into health IT. Very exciting, although also very challenging. How you do that, it's huge amounts of quote-unquote big data. We'll talk about that in a moment. There's also, in my opinion, as a health policy and management professor, all types of ethical issues and cost issues. Today, even if you had all the information you needed on genetic information on a patient, there's only so much that you actually could do as a clinician or public health professional. And if you could do it, it might cost some astounding amount of money and have of limited impact. On the other hand, now and forevermore, the genomics will be key. So the biometrics on this slide, by the way, this was adapted from an interesting slide by the European Union, EU. If you think about the full array of sort of streaming of clinical information, we have colleagues here at Johns Hopkins taking the information in an ICU. Again, that would be more clinical informatics. Those of us in public health are pulling information, social data, data from schools, data, as you see over on the left, particulate matter, environmental data. So it's really just limited to your imagination and energy over your career. If something is useful to understand the health of a community, the health of individuals, it can be integrated into this clinical database for the benefit of population health. So this wraps up Section A, where I've attempted to give you an overview of new paradigms for health information technology, EMRs, and given you sort of a foreshadowing of how they can be applied to public health and population health. In the next section, Section B, I talk about the importance of health policy and public health and the role of HIT in transforming healthcare systems and medical care toward population health and public health.